So last lecture we started by uh, discussing the results of this weight-bearing experiment where we're looking at proprioceptive feedback given to people through manual guidance or giving people knowledge results of their weight-bearing status. And what these results showed is that the 100% guidance, although they were good in practice, they did poorly in retention. The best group was the 33% knowledge results group in retention. And we also discussed why the 100% KR group faded or forgot the skill across time quite rapidly. And this is thought to be due to the fact that 100% feedback is thought to suppress someone's own intrinsic error detection and correction process. So if you give them too much feedback, they don't learn to process what they're doing wrong, and how to improve it next trial if you're continually giving them feedback. So we're going to talk about later on in the semester, but the idea here is we should give them less feedback or fade feedback away as they go through their treatment or the learning stages. All right, so then we looked at some of the motor control approach assumptions, how this is based on a dynamic system model. Patients are self-organizing systems. We talked about this before. Movement emerges out of function of constraints and resources, the constraints being task, organism, in that case the patient, and the environment. From a dynamic systems perspective, the language of the nervous system is the task or the function they're trying to do, not movement patterns or muscles or motor programs. So we should structure our treatment around tasks, particularly fun tasks or functional tasks that the patient actually wants to do. I gave an example of drumming where you can increase the pronation and supination of a child who's holding a drumstick. As they try to hit the drums, the task is hit the drums and make noise rather than pronate and supinate the hand. Reaching, another example where you reach into space to try and put your weight over a hemiparetic side, or should you reach for an object? When you reach for an object, we have a goal to get to, you'll reach further than if you have just reaching for the sake of it. So every time you incorporate task into treatment, you get a better or different outcome, usually better than if you're just doing that movement for the sake of doing that movement. Remember, task is one of those three constraints that influence how a movement emerges. And these are just some examples here of papers that have looked at that. I gave the example of pushing a coin across a tabletop. You reach further if you have to push a coin than if you just reach without a coin underneath the finger, if you're just reaching for the sake of it. And then this is a very classic test for balance, and it is correlated with things like falls and that kind of stuff. But there's no real function in this reach at all. They just reach into space for the sake of it. I think you'd find a different result if you had some kind of function tied to that reaching behavior. All right, so guidelines from remote learning approach for the treatment of patients. Identify the rate limiter. What is the thing that's preventing the production of that movement? That can take some skill. Manipulate the control parameter. What can you do to move that patient away from that undesired movement pattern? For example, we looked at the finger wiggling experiment. The control parameter there was rate of production or speed. As you told the person to go faster, they switched from a out of phase relationship to an in phase relationship. So that's the control parameter in that situation. It's speed. In children, control parameter might be motivation, for example. If they have very low motivation to do anything, that's not going to happen. Encourage problem solving using oscillating dynamics. Remember, the limbs are coupled together in phase or out of phase. And we look at examples in a minute on that. And then we try to figure out how you can manipulate the constraints of environment, task, and organism, in that case, the patient, to try and get the movement to emerge out of the result of those constraints. Okay, so then we looked at some examples of bimanual coupling or bimanual coordination, where two limbs are linked together to produce in-phase or out-of-phase movements. And there are attractor dynamics, intrinsic dynamics that move those limbs in a certain way, and it's difficult to make any other pattern. We looked at Jill Whittle's work, where it's been used extensively in patients with stroke. You can find that you can make the hemiside move better if you couple that movement with the good hand on the other side. So move in phase movements first, and then move to out of phase or anti-phase movement. So both arms, both hands reach for an object at the same time, or two different objects, pick up two balls rather than going through just using the hemiside by itself. You find that when you couple the limbs together, you get better movement in the hemiparetic side. After a while, you can remove, through treatment, you can actually remove the good hand, as it were, doing the bimanual coupling, and the hemiside maintains much of those benefits it's learned when you did bimanual coupling. And I gave some examples of that. Jill Whittle has got this, uses backtrack, which stands for bilateral arm train with rhythmic auditory cueing. And that device now is called Tailwind. You can Google Tailwind therapy, and you'll see some videos. We won't show those now. We showed them last time, of people using this device, and they report, significant improvements in upper extremity function after using this device. You can, just knowing that you can use this bimanual coupling to improve motor behavior, you don't have to buy the device. You can just use imagination to come up with tasks a patient needs to perform in a bimanual manner, and you'll find that helps the coordination of the hemiparetic side. Eric was a student who looked at lower extremity, and he found it started to work with lower extremity bimanual coupling too. Then we spent a little while talking about Parkinson's disease and how the basal ganglia degenerates, loss of dopamine. It results in the loss of the internal cue to move, which comes out of the supplementary motor cortex. So there's various treatment approaches to improve people with Parkinson's disease movement by giving them external cues. And this is one I looked at using visual cueing. People looked at auditory cueing and found some effect of that as well. Remember, in people with Parkinson's disease, everything tends to get smaller. So micrographia, small handwriting, step length gets smaller, facial expressions get smaller, arm movements get smaller during gait, the voice gets smaller, quieter speech. So there was a technique called the Lee-Silverman voice treatment, what was looked at by a speech therapist, where the people with Parkinson's basically shout, and that's being applied to movement. Now it's called LSVT big. So PTs are using this technique to try to improve amplitude of movement in people with Parkinson's disease. The amplitude shrinks, as it were, gets smaller. So in these treatment sessions, you really, really emphasize large amplitude, ballistic, high force movements to try to fight that natural tendency for everything to get smaller. And there's quite a bit of research or some evidence that does help. I looked at visual cueing, constraints of the visual environment to drive gait. So I use an external cue here because the internal cue to move is deficient. And people with Parkinson's disease take smaller steps, slower steps. They're bradykinetic, bradykinesia, small steps, shuffling gait. I talked about fascinating gait, where sometimes the steps speed up. Looked at pedestal turning, where they turn, as they turn, they take lots and lots of little steps in place. And sometimes you'll see retropulsion gait, where the patient starts walking backwards after they turn. Anyway, so what we did here was, as a student project, we had a lady come in and walk up and down 10 meters for half an hour, twice a week, and we monitored her any improvement in that step length, and we didn't see any real improvement in step length over a month of extra walking practice. We put lines down at 110% of a step length, base step length here, and we found she could step over those. After 5 sessions, we went to 120% of step length. We moved the lines and made the steps larger, longer, and we found she could do that. We brought her back 1 day, 2 days, 1 week, 2 weeks, and a month. And as you can see, initially she had her step length wasn't as good as the end of practice, but she was self-medicating herself with dopamine because she had a bad cold. When she stopped doing that, this was her step length. So a massive improvement in step length compared to the baseline due to this visual cueing. Same thing happened for velocity. This is baseline velocity for a month. This is velocity improved gradually or across the month of practice. We didn't tell her to improve and walk faster. We just gave the steps lengths, and she naturally took bigger steps, and therefore her gait velocity increased. This is the gait velocity retention. And you can see 1 month after, she's walking very well, much faster than she did at baseline. So these visual cueing really does seem to have an effect on a learning effect, not just acquisition. It actually carries over functionally into when the cues are not present. And I've used this in many people with Parkinson's disease, and I find the same effect instantly. People can walk over these lines and improve their step length and their gait speed. In my treatment, my therapeutic goals, I always have a step length goal for patients with Parkinson's disease to improve it by 10% or 20% long-term, short-term, long-term goals. People have followed up on this work. We won't show you these videos. You've seen these videos before. I showed these little angle diagrams and phase plane diagrams, basically showing that after treatment, there was a greater range of motion in the hip and the knee, particularly in the hip. It was getting more hip extension, you can see here, and the stance phase was smoother in the white lines and the red lines. The white lines is the stance phase from heel strike to toe off here, post-treatment than pre-treatment. And lastly, we looked at a couple of videos. This was a video, I won't show it now, but that was showing the laser pointer coming out of a walker, a rolling walker, and people with Parkinson's disease could step over that laser line and greatly improve their gait quite rapidly. This one was the Gait A device, where the patients see projected onto the floor like a chessboard pattern, and they walk over those, and again, drastically improves gait, helps prevent freezing at doorways and elevator in this case, and there is some significant carryover when they take that device off. Okay, that was it, I think.